you in tertiary care centers to, it is your everyday.
But
And
that's
it's
not,
not everyone's
it's
everyday.
good
That's
to
our
get that
everyday.
reminder that, yeah,
Yeah, it's our everyday as well. We have our moderator group, our volunteer group who supports all of our members. We can smell the preeclampsia in people as they come into the group, and we see, I would say we see more patients with preeclampsia than any clinician does in a
yeah,
day, because
right.
we see 1,000 of them a month. But our goal really is to empower, educate, support our patient members to have good conversations and engage with their care providers. We can do the back end support and lift and scaffold, and we need them
But that's
to
huge.
have
Yeah, that's huge.
right.
Yeah.
We need them to have great conversations with their care providers, and I think one of our superpowers is really empowering patients to have conversations and to say the right things. And hopefully we'll talk about this a little bit later, to
Yeah.
get their doctor's attention, right? We know you guys have 10 minutes, maybe 15 on a good day to spend with us at our appointment. So if we can teach them the words to say to, engage
The
their
words,
physician.
the warning
Yes.
signs, because, as much as we, I try personally to stress those things, but,
Mm-hmm.
when you're talking
Yeah.
quickly and you're moving quickly, some of these things, you're like, oh yeah, my doctor did kind of mention that maybe, but if you have somebody like yourself in your organization that's making
Yeah.
it very clear that these are warning signs to watch for, I mean, that makes a huge
Yeah.
difference.
Well, and I think the nuance in those symptoms as well, because because the symptoms of preeclampsia so overlap regular normal
Fuzzy.
pregnancy.
Yeah.
Yeah. And so helping people to understand, what that nuance, what those differences are, I think is really important, not only for them to have that conversation with their clinician, but also for them to be able to sleep at night, right? Yes, you had some swelling in your ankles, and here's why that's, likely normal. And we can prove that out because your doctor did this test and that test, and they talked to you, and right, and they felt it was safe for you to go home. But having those nuanced conversations, I think, is something that we do that, hopefully we're, supporting your work as well, and taking off some of that, emotional labor as well. And, I'm sure you get emails through your systems all the time about, pregnancy concerns, and we want our patients, our members, to talk to their clinicians and report new symptoms and changing symptoms. But we also want them to be empowered of, what is normal in pregnancy and what is cause for concern. So, hello, everyone. Thank you for joining us and listening in here in the last couple of minutes of our candid conversation before we get started. We always give people a few minutes to get connected to our webinar. If you're joining us on Zoom, hello. Feel free to type a message. Let us know where you're coming from, where you're watching us from, in the chat. If you have questions during our talk today, feel free to put them in the Q&A. We will get to them. We will get to some of those if we have the time to do so. And I imagine some of the questions we're going to go ahead, and we took some questions from our audience, and we're going to answer those. But if you have additional questions that we don't get to during the talk today, we'll try to get to some of those at the end. If you are watching us live on our Facebook live stream, I'm going to do my best to also manage that channel over there and see what questions we have. But I'm a Gen Xer, so my technical abilities have limitations, I like to say. So if you're watching us there, also feel free, please tell us where you're watching us from. We have a global membership here, people from all over the world. So we love to see people as where they're coming from. This is one of our earlier webinars. We often do them in the middle of the afternoon, but I'm hopeful that some of our European folks can catch this one in real time rather than watching it at the wee hours of the morning or on video later. But let us know if you have questions along the way. We'll try to get to those. And I'm going to do some introductions here. Let me get over to my notes as well. I'm Cara Belt. I'm the founder here at endpreeclampsia.org, and the Facebook support group, if you're watching us from there, is one of our is our primary program within the organization. So thank you for joining us today. We are having a great conversation today about biomarkers. As you know, we've been talking about biomarkers for a long time, somewhere, 20 years or so. But we've talked about them a lot this month, which is Preeclampsia Awareness Month. It is the last day of May. This is the last day of Preeclampsia Awareness Month. But today is not the last day. We will share our stories and spread awareness. We want to continue that throughout the year, but we're really grateful to have two fantastic young clinicians and scientists with us today to talk in more depth about what we keep calling the preeclampsia test, and what you might have seen us talk about in the Facebook group. We've had some talks, some additional webinars earlier this month on the topic of biomarkers, but I really want to talk about how you as patients can have a conversation with your physicians about whether this test is right for you, and what it can and cannot do, how it works, all of those good things. A quick plug before we get started. We are the proud recipients of a PCORI Engagement Award. PCORI is Patient-Centered Outcomes Research Institute. That means they've given us some money to develop a patient prioritized research agenda. What that means for you is we want you to tell your stories and tell us what's important to you in research around hypertensive disorders of pregnancy, so that we can provide that to our researchers and say, hey, this is what the patients are interested in looking at in research. Can you go do that? Can you help us with this? If you would like to be a part of that, we have our ambassador program. We're taking applications. We're looking for around 75 of our members this year. We had a whole group last year of 75. I'm going to post a link in the Facebook chat, and I'm also going to post it in the Zoom chat. There's small stipends that go along with that. So we're going to pay you for your time and participation, for helping us help research. So we hope that you'll apply for that. And now we're going to get started. So I am delighted today to be joined by Dr. Tooba Anwer and Dr. Ravi Chokshi, who are coming to us today, like I said, to talk about biomarkers. And we're going to start. Dr. Tooba Anwer is a practicing maternal-fetal medicine physician at Brigham and Women's Hospital in Boston, Massachusetts, specializing in the care of patients with hypertensive diseases of pregnancy. That's all of us. She's presently an instructor at Harvard Medical School, and her research interests have been in the utility of biomarkers to predict the risk of persistent hypertension after pregnancy. We're going to talk about that towards the end of the hour. I added a whole question about that after I read through your bio, Dr. Anwer. And then Dr. Ravi Chokshi is a current maternal-fetal medicine fellow at Penn State Health. He's board certified OB-GYN in critical care medicine. He practiced in both specialties for 6 years prior to returning to the MFM fellowship, maternal-fetal medicine fellowship. Dr. Chokshi has extensive leadership experience and previously served as physician leader of an OB-GYN practice with over 20 providers in Florida. He's actively involved with SMFM, which is the Society for Maternal-Fetal Medicine, as a member of the Patient Education Committee. His research interests include the role of placental biomarkers in fetal lung injury and adverse neonatal outcomes. That's also important to this group. He has multiple peer-reviewed publications, a textbook chapter, and has been invited speaker at several conferences, including the Florida Hospital Association. Offline, Dr. Chokshi, I want to talk to you about the SMFM Patient Education Committee. I tried to apply, but they don't take patients on that. So I would love for you to put in a word for us to see if we can get some patients on that committee.
Yeah, absolutely.
Welcome. Thank you guys so much for sharing your time and experience with our audience today. We know you're both very busy, and we really appreciate you making the time for this important conversation for us. So, we're going to go ahead and get started. I want to talk a little bit about the biology of preeclampsia. Dr. Chokshi, our group has learned about implantation and how poor implantation can lead to complications like preeclampsia. Can you talk a little bit about implantation, spiral arteries, and kind of the time frame of, because I think our members think of implantation as being that those, first couple of days after fertilization. But I'd like to hear more about what you have to say about this whole time
Or
period.
Yeah, I mean, I'll preface that. Thank you for that lovely introduction, by the way. I'm going to try to share my screen. You let me know if that works okay, where I can at
We
least
got
flip
it.
through the slides, and I can flip through
Yeah.
the slides. This is just
Yes.
this is mostly a visual kind of aid. So I am not a placental pathologist. I'm not a, expert in that field, but I am interested in preeclampsia. And, what we understand of it is still evolving. Every few years, I feel like we go back to the drawing board and like, aha, this makes more sense now because we're learning more about the disease. I'm sure, Dr. Anwer will, either agree or have her own input on this, but preeclampsia is it's a term for a very diverse disease. There's not one single preeclampsia, right? And what we do know fairly well now is that early preeclampsia and late preeclampsia are really two different disease processes. Early preeclampsia tends to be that placental disease, that poor implantation. This is when the patients get like really sick, they get HELLP syndrome, they go into DIC. This is where that prematurity and that NICU stay and all that morbidity comes from. And that is like a different disease, and how it behaves is a different disease. And then you have this late preeclampsia. These moms are usually healthy, maybe 38, 39 weeks. They'll start having some blood pressure issues. They may get diagnosed with preeclampsia. They'll get delivered. They tend to do okay. Obviously, not everybody does okay, but they tend to do okay. These babies tend to do well. And, it tends to resolve, and there's not a lot of long-term sequelae from that disease. And that tends to be a different disease than that early preeclampsia. And we understand that better now because we'll talk about the MIRV data. We'll talk about how aspirin works for trying to prevent preeclampsia, but it doesn't work for all kinds of preeclampsia. And that's why we do know that this is a very heterogeneous or a disease that can't be kind of like put in one box, right? So talking about placentation, when you have this early embryo development and this blastocyst and this invasion, I don't know if you can see the slide here. Really, the interesting thing to me is in that early first trimester, the placenta that's forming is almost protecting the fetus from a high oxygen environment that the mom has. It doesn't actually want that much nutrient sharing between the mom and the placenta, and a lot of the nutrition is coming from that yolk sac, so really from the embryo itself. Um, and afterwards, so this is when that critical period after the 13-week mark until really the entire pregnancy is when that placenta is making those deep connections. And I always find this surprising, but even medical students is like there is no direct sharing of mom and baby's blood. It's those two blood streams never connect directly. The placenta is the medium of exchange. It's this black box in between that does all the nutrient transfer, but they never touch directly. So for that placenta to do its job, it has to actually invade into the maternal circulation. And I thought this was a decent cartoon that showed this is a pregnancy where this is a patient that's not pregnant. You have your normal spiral artery, and that's maintaining the endometrial lining or the decidual lining in pregnancy. And then you have a normal pregnancy is when you have these cells, and again, not to get technical, but these cytotropoblasts that are invading and remodeling. They're basically changing and altering these spiral arteries to allow for a good vascular connection between the mom and the placenta. And when you have these abnormal placentas, you do not have a good invasion. So you end up with these vessels that are poorly formed, not really remodeled, and you have basically this unhealthy implantation. I think there's a good graphic maybe later. Well, this might be the best one I have here that shows that you have this like nice big vessel that can share oxygen, that can share nutrition, and as the baby grows, it can kind of keep up with the metabolic demand of that baby, and the placenta does great, and you have a healthy placenta that gets you to term. Or you have a poor placenta that never really formed those good connections. And what happens is as the baby grows, it cannot keep up with the metabolic demand. So eventually it basically, that term we use for that is it's chronically hypoxic, which means that it is not able to maintain the oxygen needs of that fetus. And that chronic hypoxia is basically is a bad state to be in. It is going to cause release of other factors that is now going to make the mom sick, and that's going to potentially make the baby sick. And that's the easiest way to describe. You have a healthy placenta, you have a poor placenta, and the poor placentas are where we see that early onset preeclampsia. When people have studied and looking at like blood supply from the uterus to the placenta, they you look at urinary Doppler. So this is kind of like a waveform of how blood is going between to the uterus. And a normal, there's not a lot of resistance, so the blood supply can actually go fairly easily. But when you have a placenta that does not implant well or does not invade well, you actually have more resistance, and that changes the waveform. And this has been used, Fetal Medicine Foundation, they're, in UK, they
Europe,
use this as
yeah.
like they use this as an early, predictor of patients developing preeclampsia. Not commonly used in the US, not like supported by our guidelines, but there's science behind this. So that early placentation can be studied with, tests like Doppler.
So we get a lot of questions about why preeclampsia isn't diagnosed prior to 20 weeks. And I think maybe you just sort of explained why that is, right? That demand of the demand of the baby, um, as that baby gets bigger, 20 weeks and beyond, adds, has more requirements of for oxygen and nutrients from the placenta, and it's at that juncture where that the placenta starts to fail, right? Where the placenta can't keep up with the demands of that baby. It sounds like that's has
I
something
mean,
to do with that
that's
sort of time frame.
Yeah, that's part of, I think, so classically we're trained that preeclampsia cannot exist before 20 weeks, okay? And that any hypertension before 20 weeks is you have hypertension, you have high blood pressure. You may not have been diagnosed by your primary care provider, but you have essential hypertension, you have chronic hypertension. And then after 20 weeks, you develop new onset hypertension. I mean, that is the literal, textbook ACOG
Textbook,
definition of preeclampsia. You know, we know in medicine, nothing 100% follows a textbook.
sure.
The easy way I've found to explain it is this is a placental disease, right? You need a placenta that's actually big enough to cause disease. So when we look at, the rare situations where you can get preeclampsia less than 10 weeks, and it's very rare. I mean, that's not a common occurrence. For most patients, for most practical purposes, preeclampsia does not develop before 20 weeks. But if you
Yeah,
look at those
there's a
rare,
handful there's a
yeah,
handful of case studies, right,
yeah,
where it does
yeah.
exist, but
Absolutely, absolutely. I'm never going to say it's
yeah,
0%, but it's one of those like extremely rare events. But it
yeah,
tends to happen in situations where the placenta is a huge part of the pregnancy already. So we classically are taught molar pregnancies because they're
mhm,
almost always just placenta. That entire
mhm,
pregnancy is placenta. The more placenta you have, the more placental diseases you have. So you have early preeclampsia. Multiple gestations, twins, triplets, and even those it would be rare. But again, the more placenta you have, the more likely you may end up with that. Classically, we see if you have preeclampsia like symptoms or preeclampsia like features before 20 weeks, you got to look for an alternate diagnosis. Does this patient have lupus? Does this patient have an autoimmune disorder? Does this patient have underlying renal disease? That is really the pathway we go down on, because to get pure preeclampsia less than 20 weeks is one of those, super zebra events. It would not be a
right,
common occurrence.
right, great, great. Thanks for that clarification on that. Um, is there a way to monitor implantation? If implantation is the problem here, is there a way to monitor that?
I'll just give my
I know
little
the
like
answer,
thing on it.
but
Yeah, yeah. So I not that I am aware of, I know
yes.
REI is doing research and like looking at implantation disorders because of course, so much of their science is why is there recurrent pregnancy loss? So they're looking at that immune interface between mom and implantation of why certain placentas implant well and the pregnancies do okay and some don't. So there's developing science behind it. I personally am by no means an expert in that. I think, we can talk about this later is like, are there methods to try to give a risk for are this patient going to develop preeclampsia in later pregnancy or have fetal growth issues later in pregnancy? There are some tests that are being utilized for that. But I'd love for, my colleague to, give her input on this.
Yes, I completely agree, Dr. Chokshi. It would be something very helpful to be able to monitor that, but we just kind of don't have that beautiful gold standard diagnostic test. And when you think about implantation, the first thing that comes to my mind is earlier pregnancies when you're trying to establish a viable pregnancy, rule out ectopic or intrauterine. Then we use HCG levels. That probably rings a bell to people in early pregnancy to see, is this pregnancy going to continue? Is this pregnancy sort of implanted? But that's really the most basic use I think we have is like, is this pregnancy continuing or is it going to end in a very early first trimester loss? But aside from that, that's kind of like the bread and butter, I think, and it doesn't get more technical past that, unfortunately.
Yeah. Yeah, like I said, unfortunately, I knew that probably to be the answer, but I wanted to ask and see, about that. That's one of the questions that we get a lot from our patient members. Well, if this is the problem, why aren't they looking at that? And I think there's probably a lot of barriers there for that to be for that to be useful. We know placentas in pathology come out all different sizes and shapes, and you also have a growing fetus as well to manage in there. If someone is we talked about you touched on if there are symptoms prior to 20 weeks, you're gonna want to look for other causes for those symptoms. HELLP syndrome, we know though, can sometimes pop up prior to 20 weeks. What's your thought on
I actually
that? Is
tried to look up that because I saw
Yeah,
that, you sent me this yesterday.
yeah,
And I'm not, HELP is on the spectrum of preeclampsia. It's a severe
yeah,
form of preeclampsia. Just as, it's very unlikely to have preeclampsia before 20 weeks, it would be
yeah,
very unlikely to have HELP. You may have, again, the patient, if you have underlying lupus, if you
yeah.
are renal disease on dialysis, these patients tend to get sick in early pregnancy. And then sometimes it may be attributed to preeclampsia or HELP, but really there's an underlying
It's an
disease process
underlying
that the
disease
placenta may
process.
have worsened, but it's
Hmm.
hard to blame it purely on like a preeclampsia picture.
Gotcha. Great. Thank you for that. Thank you
Yeah.
for that clarification as well. Um, is there anything our members can do to prevent poor implantation or assist in better implantation? Also a common
So
question. We as
that's
mothers look to ourselves, right? There's a
right.
lot of guilt in our community. What did we do? What did we not do? So is there anything we can do?
Which is just it's just amazing, right? Moms are they just cannot stop caring, right? They're always like, what can we do? And I know that from my own family, my own wife. Um, the simple answer is there's not a ton, but there are things that we know help, right? So aspirin is huge, and we'll talk about aspirin in this talk. And that is, recommended after 12 weeks, ideally started before 16 weeks. We have a lot of evidence that it helps with that early form of preeclampsia, not necessarily that late form of preeclampsia. So if there's one medical intervention, it's going to be aspirin. We really have nothing else to offer. But there are things like if you are planning a pregnancy, you're not already pregnant, everything you can do to make yourself healthier is going to reduce your risk for preeclampsia. If you are overweight, losing weight, if you have hypertension, again, losing weight, trying to manage your hypertension before you get pregnant. If you have an autoimmune disorder, if you have lupus, getting them to be as what we call quiescent or, no flares for 6 months before you get pregnant. So stabilizing and improving your health, you have diabetes, getting your blood sugars in control is probably the best way to reduce any complication of pregnancy, including preeclampsia. And some of that, the physiology is, we think that when the placenta is implanting, if you have this interface that's chronically inflamed, so when you have these metabolic disorders like hypertension, obesity, diabetes, the implantation is not going to go as well. But if you're able to reduce that chronic inflammation in your body, then you're more likely to have a healthy placenta. So that's probably one thing that patients can do.
Yeah, I was just going to add to that because, like you were saying, people can't help but feel guilty and think about what did I do to cause this? And I kind of joke with patients that, unless you're like using a bunch of cocaine or something like that, you really can't do a lot to like cause this to happen to yourself. So that's the first thing. And a plug for knowing your hypertension status, I think is important because, we're lucky as MFMs that we get to care for patients in a time of their life where they're many times very invested because for their own care, but for their baby. And having good follow up with their primary care physician to really understand what are my blood pressures. As the incidence of cardiovascular disease is rising, more people have hypertension. And so knowing that diagnosis, getting an ambulatory blood pressure monitor with your PCP, establishing that, and then being on the right antihypertensive medications, especially with the categorization of hypertension to be even lower now for blood pressure. So that's a really important intervention that we could do before going into pregnancy, which is certainly modifiable.
You make a great point there, and we talk to our members about this a lot, those particularly who have sort of out of the blue developed hypertension prior to 20 weeks. And they're like, but it's normal usually, and I'm so healthy. And when we ask some more questions, we find out, well, their blood pressure prior to pregnancy was really like 125 over, 80. And the old standard used to be 120 over 80, but that criteria has been changed outside of pregnancy, at least. I know they're talking, there's work being done on what should be considered normal in pregnancy. But now really 120 over 80 is considered pre-hypertensive outside of pregnancy. And we know it takes a really long time for changes in medical recommendations to kind of filter down through healthcare providers. And so we go like, oh, well, you should maybe talk to your doctor. This is likely a chronic hypertension. And maybe it was, within reason outside of pregnancy, but now this additional strain on your body from the pregnancy, has caused that blood pressure to go up. And you're likely chronic hypertensive, not gestational hypertension. And there are some differences there, and treatment may look different, and delivery recommendations may look different. So that's a great point, I think, to mention that those hypertension numbers have changed.
Yeah.
And then on the healthier pregnancy, making yourself healthier, even if it doesn't prevent preeclampsia, being healthier helps to have an easier pregnancy, an easier delivery, all of those things. So just in general, that's good advice. And some of our members will say, oh, I just found out I'm pregnant and I stopped all of my medications. That's not necessarily the right thing to do. The right thing to do is to talk to your physician about your pregnancy status and the medications you're on, and to work with them on a plan of do you need to change a medication, but stopping cold turkey on whatever you're taking is not necessarily the right option. So we like to encourage that open communication and partnership with the physician. We are, as mothers, always concerned about what we're putting into our bodies, particularly when we talk about medications. But some medications are necessary and are beneficial. And if the one you're on is maybe not the best option for pregnancy, your doctor can work with you to find an alternative. medication. And sometimes the benefit of the medication you're on outweighs the risk as well. And that's a good conversation between you and your physician, but don't
We
necessarily stop those medications cold turkey.
we love it if either the patient has had, if they're planning a pregnancy, it's always great to either meet with your OB or even get like a
Yeah.
preconceptional consult with an MFM, if you're on some of these medications, if you have chronic health problems, because not only can we try to optimize your health status before you get pregnant, it can answer a lot of the questions, take away some of the fear of these medications. So then it just, you're going to have a much safer pregnancy if you're not on and off medications. You're not potentially risking your own health while you're trying to get pregnant.
Yeah. And I think it's also important to keep your 6-week postpartum appointment as well, to manage any potential future complications as well. We know a lot of times we come out of these pregnancies with additional health problems, and we're going to talk about that a little bit later. But to kind of move forward, do we know what triggers someone to deliver at 26 weeks versus 36 weeks? You just showed us that, those implantation slides. What can you tell us
Yeah.
about that?
I mean, it comes down to the same, early preeclampsia is a severe form of disease typically. If you are getting early preeclampsia, you're getting sick, it's going to affect baby's growth. It's going to increase your chance of delivering early significantly. And these are the patients we try to like stabilize and manage. But I tell patients like it's a very unpredictable disease. Some patients we get fairly lucky, we'll see them at like 26, 28 weeks and they have severe preeclampsia and we'll stabilize them in the hospital and they'll get to 34 weeks. And some patients will get like 2 days. And we're starting to understand the pathophysiology of that a little bit more. And some of that is related to rising like biomarker levels like sFlt and how it's being released from the placenta. But we are, our goal is with severe preeclampsia is to try to get you further in the pregnancy. Typically, we're not trying to deliver you before 34 weeks unless we have some decompensation from mom's side or baby's side. And you had to remember, mom is getting sick and we're trying everything we can to keep mom safe, and sometimes we can't and we had to deliver patients, but a lot of times the baby is not tolerating this. The baby and the placenta is used to a certain amount of blood pressure, and everything we're doing is impacting that blood pressure. And as you shared your personal, we'd run into things like placental abruption, or we run into bad outcomes for the baby. So balancing that is actually a complicated clinical situation, and actually so much of our field as MFMs is managing that preterm risk while trying to keep mom and baby safe. Yep.
I think
Did
you're
we lose
muted.
you? Yeah.
How many years we've been doing this, and the mute button still gets us. I personally was delivered for fetal indicators. I was like, I can go further. I can tough this out. It's fine. And my MFM was like, yeah, but your baby isn't. So I think that's a really important note, because we will throw ourselves under the bus, right? To do the best for our babies. And I think it's important to note that don't stay home if you're having symptoms, if something's wrong, because you can't, even if you can tough it out, it doesn't mean that your baby can. There's two individuals here to consider, two patients to consider here, and sometimes early delivery is what's in the best interest of your baby, and even if that means a long NICU stay, it is sometimes, unfortunately, that is the best choice. So make sure you get in and talk to your clinician, and be seen when you have symptoms, worsening of symptoms, a change in symptoms, because sticking it out at home is not always the best answer. Even if you think that it's going to buy time for your baby, it may not. Very good. So let's talk a little bit more about this early severe preeclampsia that you alluded to, Dr. Chokshi, and this late, not always mild, so to speak. We don't
Right.
really use that term anymore, because
No.
preeclampsia in general is not mild at all. but less severe later version of preeclampsia.
Yeah, there is a lot of interesting science behind it that we're still, saying. Can you still see when I move the slides?
Yes. Mm-hmm.
Okay. So I thought this paper by Ravi on their new test was actually very illuminating, right? Because they looked at the papa2 gene that's from the placenta, and they basically two separate phenotypes of preeclampsia, where you have this early severe onset preeclampsia, which has high expression of the papa2 gene, and if you don't have that, but you have this immune mediated preeclampsia that's late. So again, there's a lot of placental science that we're still learning. I think the way it's classically been described, and please jump in, Dr. Anwer, and correct me if I'm misspeaking, is that early preeclampsia, this chronically hypoxic placenta that is releasing all these biologically active molecules like sFlt into the maternal circulation and is making mom very sick. Okay, that tends to be that severe phenotype, that early preeclampsia picture. The late preeclampsia picture tends to be, it was classically said, maternal cardiovascular maladaptation. So you have these moms that, may be a little overweight, may have some, may not be diagnosed with essential hypertension, but may in the next few years get hypertension, may in the next few years get diabetes, that kind of patient, which makes a huge portion of our patient population, right? And so there is a known immunologic etiology to preeclampsia. One of the interesting ways I've described to my residents and medical students is, so everybody says that preeclampsia, your first pregnancy, your risk is highest, right? It's not preemie gravida that actually your risk is highest, it's preemie paternity, because if your first baby with that biological father is actually your highest risk for preeclampsia. And the science behind that is you are growing a fetus that is only 50% you. The other 50% is actually an allograft. It is somebody else's DNA. And your immune system has to do all kinds of, you know, jumping over obstacles and hurdles to accommodate a growing baby inside of you that is only 50% you. Eventually, your immune system does not like it. So if you have this underlying cardiovascular maladaptation where you're prone to hypertension, prone to getting sick, eventually your body is kind of, okay, I'm done with the pregnancy, and you end up developing preeclampsia. That is like the immunologic model of late preeclampsia versus this early model of placental preeclampsia. And I'm sure there's overlap because the immune system is very active when the placenta is implanted. So how it implants, how deep it implants, all of that is related to the mom's immune system. And there was an interesting study that looked at when moms cohabitated with their partners for a longer period of time before having pregnancy, they had lower risk of preeclampsia, as opposed to if they had a short, relationship before getting pregnant, which again goes to that immunologic, you build tolerance to your partner by being with them for longer.
So you're saying that the solution here is not necessarily to get a new partner so that you can have a preeclampsia-free pregnancy. We're not advocating for
Right.
you to go find a new partner necessarily. And then if you do have a new partner, your risk moves maybe back up to the sort of that first pregnancy risk. So another topic to discuss with your care provider.
I was going to add, I learned this interesting term called bidirectional microchimerism when you think about pregnancy. And so the fetus shares cells to the mom, right? And the mom will forever have, or not, I'm not sure about forever, for a long time, carry some of the genetic material of each child that the mom has carried. And so, there's this thought that if you're the firstborn child, you're like the altruistic offspring, and you kind of pave the way for your future siblings, and your mom's body adjusts to the new genetic material from that father. And then once the maternal body has seen that genetic material, supposedly the body handles future pregnancies from the same father, potentially in a slightly better way, because that the firstborn kind of paved the way. And I kind of look at that and think about it the same way when you think about different paternal genes coming into play and how the risk of preeclampsia changes. So for all the firstborn
It's
siblings out
fascinating. Yeah.
there, you're really, really making a difference.
Yeah, I think they have found fetal stem cells still in like mom's liver,
Yeah.
and there are like case reports of like cirrhosis getting better because they had access to fetal stem cells. So I mean, the science is fascinating. I think we're in an amazing field what we get to do, and we're only going to learn more about this.
Yeah, exactly.
As the firstborn child, I approve of this messaging. Don't ask my younger brother about it, though. He may not feel the same. Very good. So tests. Now we have these biomarkers, right? And MIRV, this paper that you're just talking about, does have a test that just sort of released, I think, a week or two ago to be available, and it is a test that I think people over 35 years of age with no high risk factors, like no known high risk factors, so no previous preeclampsia, no
Yeah.
hypertension, no diabetes, and maybe hypertension doesn't fall in there. I'm not quite sure, but and that can test and tell a person whether or not they have a high risk of developing preeclampsia, and that test can be utilized between, I believe, 18 and 22 weeks
Yep.
of pregnancy, and give at least some advanced preparation time, and some maybe guidance for the clinicians as far as management or monitoring of that patient is concerned. Have you guys? This is very new, so have you guys used this test at all, or?
Not used it, just
Yeah,
heard of it, read the
yeah,
primary paper from it. I mean, it's interesting science.
yeah,
Um, I will tell you, so this comes down to it's a great test in terms of like its science. Is it a
yeah,
great test clinically? That remains to be seen.
yeah,
Because first of all, you use it 18 to 22 weeks, right?
yeah.
Which is we have better tests in the first trimester that we don't actually use in the US that have a decent, very decent sensitivity and some positive predictive value. We can
Mhm.
talk about that. But I went to their website and I looked this up. So this is the test at 18 to 22 weeks. It gives you a risk profile, right? And then this is what you do if you are at risk for preeclampsia. And I'm sorry, this is there's a lot of info on here, but really what you do if you're at high risk for preeclampsia is you start aspirin, which for most patients you should have started aspirin earlier, 12 to 16 weeks, and not at 18 to 22 weeks. So some of the benefit of aspirin is already lost. And the
Mhm.
other things are maintain a healthy diet, try to get sleep, you you take some vitamin D, which is already in prenatal vitamins. So this is the classic issue of that's great that you can tell a patient that they're high risk for developing preeclampsia, but then what do you do about it? And unfortunately, we have nothing we can do about it. You should get surveillance. So maybe that is the answer. Maybe these patients get
Mhm.
put on a track where they get more blood pressure monitoring, more growth surveillance, and it depends on, your institution. We already, academic center, we already do a lot of surveillance. Or maybe you're in a community hospital, you don't get much
Mhm.
surveillance. This test comes back positive. Maybe there's a role for it there. But so I don't mean to completely discount it, but clinically looking at this test right now, I would have a hard time using this for any of my patients because there's not much I can do with that information. If you go and look at like the Fetal Medicine Foundation algorithm for like first trimester preeclampsia, technically
Mhm.
that's a more useful test because
Mhm.
you're getting information in your first trimester. It has very decent sensitivity, but even with all their factors, the positive predictive value is only 10%. So you end up screening and over treating 100 patients to catch 10 patients that are going to develop preeclampsia. And that is why, ACOG in the United States has not really recommended these tests, is we don't really have an intervention for these patients.
Yeah.
Unfortunately, that might change.
Yeah, I think the MIRV test, the Encompass test. First of all, I know that is a first step, right? It's a huge paper, and I think that
Yeah.
the science that has come out of this is really trajectory changing for the work we've obviously within the industry known for a long time that preeclampsia is there's different types of preeclampsia. We call it different flavors of preeclampsia. And so, zeroing in on, and there's, possibly, more
There will be more
phenotypes
to come.
here,
Yeah,
right?
there will be more to
Yes.
come for sure. Yeah.
So, but to zero down and to have a paper like this, I think is a huge step forward. The test
Oh
itself,
yeah.
I think, there's certainly some. First of all, our population, at least in the U.S., 70-80% have risk factors. A huge portion will have risk factors that mean that they don't, qualify for this test. But I do know Mirvi is working. The next step will be, can they test earlier? Can they include a larger a group of people? But I think for patients, at least, it can, because these will be patients who have not had preeclampsia before, but perhaps their mother had preeclampsia with them or with a sibling, or it's in the family, and they have concerns. They can have this test and at least have some preparation, time to say,
Absolutely.
okay, this pregnancy may not go the way I had hoped it would. I maybe have to deliver early. I need to maybe set up childcare for my uh, other children, or make other accommodations, et cetera, and then just have time to process that maybe this pregnancy isn't going to go quite as perfectly as planned. Maybe they move that baby shower up. That seems to be one that
Yeah. Yeah.
takes a lot of mental toll on our patients. They're unable to get to their baby showers because they're in the hospital at that point. But yeah, we're excited really about this paper and about the science,
I think the science is
yeah,
super fascinating, honestly, and some of it was way beyond my head. So I'm not even a claim to, but you don't have to convince me. I think more information to patients, giving them some
Mhm.
predictability.
Yeah,
I think all that is great. I wish we had a better intervention for preeclampsia. Maybe that's on
yeah,
the horizon.
yeah,
And Dr. Anwer, I don't know if your institution does this, but I mean, we advocate aspirin to so many patients, right? And our compliance rate is still not great. I think
Yeah.
the number one thing we can do in this country is probably educate more patients on the benefits of aspirin for pregnancy, and improve compliance, because we would probably reduce so much preeclampsia, especially early preeclampsia. And more to talk about the topic, what dose of aspirin? Because we're probably using an inadequate dose of aspirin in a lot of our patients. So these are
I think,
things that we could definitely optimize.
yeah, I think the way I kind of looked at this study was that I think what they were trying to get at, my basic understanding is that it's that population where you don't aren't suspecting the preeclampsia to occur in, right? Like
yes,
our the table by the USPSTF ACOG that lists the high risk factors, the moderate risk factors, and then you look at the table to decide, oh, is this person's risk of
Which
preeclampsia
is, yeah,
elevated? Should they get aspirin? And those, I think, even for us as clinicians, you can see the patient's medical history and kind of know, this person from their medical history is at increased risk. But it's that group, the group that develops the early preterm preeclampsia, where
with no
you
risk
don't have
factors.
the risk factors. And I think that's what they were looking at, like older, like 35 plus, but not as many risk factors. So that's where it would be helpful, I think, because you don't suspect it in those patients. But I think the topic you brought up, Dr. Chokshi, is that the timing of it potentially, like if you're when we talked about spiral artery modeling and implantation, like the time at which this test is done, potentially if that could be sooner so that you can have the intervention in that high risk population that you weren't already going to start aspirin on, you weren't suspecting. So that seems like a little bit of maybe the adjustment that would then be very helpful in your otherwise low risk unsuspected patients. And with the aspirin thing, I've like really become a huge proponent of two aspirins. I know it's like not truly with what the original study was, and here it's 81, but like definitely a two
Yeah,
aspirin kind of
yeah.
girl here.
Yeah, yeah. I mean, we risk triage our patients basically and say you are probably at a higher risk and you should take two baby aspirin because we don't have the 150 milligram that the aspirate trial used. And
Yeah.
so that's a patient advocacy thing for sure. Talk to if you're worried about developing preeclampsia, if you have a history, you can advocate to maybe potentially get prescribed two instead of one. And there is data behind it. It's not endorsed by our national organization yet, so there is some reticence. Not everybody is comfortable with the two aspirin, but most MFMs are,
Yeah.
especially in my bubble.
Dr. Majid Constantine out of the Ohio State University is doing a big PCORI trial, comparative effectiveness research on the different dosages. So we're excited. I mean, that study's a little, ways down the line before we're going to get some answers, but we're excited to see that as well. And I think the answer here to aspirin is talk to your clinician. What you get recommended is going to have a lot to do with your medical history, what research your clinician has seen, and like Dr. Chokshi mentioned, talk to them if you think that a higher dose may be beneficial to you. Talk to your clinician about that. Don't just don't self-treat, and if you are, at least be honest with your physician about what you're doing.
Yeah.
But you can advocate for yourself for
But
that as well.
honestly, the lowest hanging fruit, and this has been shown in study after study, is just getting the patient to take the aspirin. Which, so if you can tell your family, your friends, like, listen, if your doctor is recommending aspirin, first of all, if they're not, ask them if they should be taking aspirin, because a lot of
Yeah.
times this gets missed. And if you should be taking it, do actually take it. It is one of the easiest ways to reduce the risk of preterm preeclampsia. It does not take away preeclampsia. It will potentially get you a few more weeks of pregnancy before you develop
Yeah.
the preeclampsia.
Yeah. Very good. All right. And then I would like to move on to really the major topic of our conversation here, even though we're in the last few minutes of our talk, the Thermo Fisher Preeclara test. It's now called Preeclara. They just kind of announced that name a few weeks ago, I think, but it is what we've been calling the S-split PLGF ratio test. And this is looking at different biomarkers than what you have on your slides here. And I'd like to ask,
I have that too.
Dr. Anwer here. Our people would love to have a test that tells them prior to pregnancy or in the first trimester that they will or will not, get preeclampsia, and we don't have that available to us yet. Maybe someday in the future. Could you just spend a minute talking about the difference between prognostic and diagnostic tests?
Yes. So, and that's a great point you bring up, Kara, because we really need to know the crux of what the difference is. And so, I would say think about it as if you're, feeling unwell and you go to the doctor's office and they're going to use different tests, right? So, the main job of a diagnostic test is to identify and say yes or no. Is the disease there? Yes, or is it there? No. You're kind of like a detective. You're trying to answer kind of a yes or no question in simple terms. So you have a sore throat, you get a strep throat test. It's either positive or negative. You think you broke your bone, you get an x-ray, you see a fracture, or you don't. That's a diagnostic. It answers yes or no. So on the other hand, a prognostic test is a little bit different in that it's not a yes or no question answer. It's a what is going to happen in the future if you have a specific condition. So an easier way to think about it is someone who may have been diagnosed with a certain type of cancer. And we look at certain tumor markers in the cancer. And if you have that tumor marker, it's not telling you that you have breast cancer. You already have breast cancer. It's telling you what your survival might look like. It's telling you how you might respond to chemotherapy. Or, for example, if you have signs of heart disease and you use the ASCVD risk calculator, it kind of tells you what your chances are of having a acute coronary syndrome or cardiovascular event in 10 years. It's not telling you, yes, you have heart disease or yes, you have a stroke at this time. So that's kind of the two different ways. Diagnostic is it now, and prognostic is will it happen in the future.
And so all of the tests we've been talking about are prognostic. They are looking at a risk factor. You have, based on this test, you have an increased risk. And that is the same with this Preeclampsia test from Thermo Fisher, which is cleared by the FDA in 2023. So we've had it theoretically available, but it's really this year starting to pick up some steam. And it looks for these two biomarkers. And can Dr. Anwer, can you tell us a little bit more about this test?
Yes, so the test looks at a ratio of two biomarkers. One is sFlt1 and the other is PLGF. sFlt1 stands, the long term is soluble FMS-like 1 tyrosine kinase, and PLGF is placental growth factor. And just for simple terms, the sFlt, like Dr. Chokshi mentioned, is what we think of as the inflammatory or anti-angiogenic, meaning it's kind of fighting the placenta. So it's anti-pregnancy is kind of the basic way that I look at it. It's preventing placental growth. He has a slide pulled up here as well. And then PLGF, I think of in mind is like it's a sign of how healthy the placenta is, and it's the more you have of it, the more you think the placenta is functioning and doing well. So when you look at the ratio of the bad over the good, kind of in layman's terms, the higher the ratio you have would mean that you have more of the anti-placenta hormone, the molecule, the sFlt1. And so this test found a kind of a ratio that measures these two molecules, and if your ratio is greater than 38 or 40, it tells us that you have an elevated risk of developing severe preeclampsia within the next 2 weeks. It doesn't say you have preeclampsia. It says that your risk of developing it in the next 2 weeks is very elevated. So I think the sensitivity is like 94%.
Yes.
So pretty good at predicting whether or not you'll develop severe preeclampsia.
And there's been and then there's been a couple of follow-up sort of studies. So that came out of the Preeclampsia study, and then there's the Beacon study, which have shown like that higher that number of the the ratio number, sort of the faster you're potentially going to develop those severe symptoms. So it's good for 2 weeks. So if that number is lower, the Thermo Fisher test cutoff is 40, the Roche cutoff test is 38. If it's lower than those cutoffs, then what does that do? What, as a clinician, what does that help you do?
Yeah, I think it overall, in my mind, when I use this in patients who have started to develop hypertension or may already have chronic hypertension, and now and something has changed. Blood pressures are higher, maybe some lab abnormalities, maybe the baby is growth restricted. And now I'm using this test to say, well, now that it seems like there's a clinical change, is this clinical change suggestive of impending severe preeclampsia? If the ratio comes back less than 40, I feel pretty reassured that the likelihood that this change that's happening is because of severe preeclampsia is low. It may be a general change or worsening of their baseline hypertension, or it's not technically approved for this, but also if it's negative, but you have lab abnormalities, high blood pressure, you think of other causes like Dr. Chokshi had mentioned, lupus, renal conditions. So that's how I kind of use it is, oh, I'm worried that preeclampsia is going to develop in the next, severe preeclampsia will develop in the next 2 weeks, or I'm more reassured that it's not going to.
Yeah, we're using it to help discharge. Which is making a huge difference to patients' lives because we're not keeping them in house for weeks on end on carefully selected patients. So, and I think that is actually, there's two benefits. There's, as you said, the Beacon trial where the patients who were discharged home with the negative test did well. They didn't have any adverse outcomes. So we have some real world data. and then they mathematically modeled that to see neonatal cost savings. That was an interesting, but showed like for every time you ordered the test, you were saving $10,000 for NICU stay, you know, just to kind of reduce the amount of NICU time that these babies were getting.
Yeah. And then those patients would be followed as normal, whatever the standard of care is, maybe even the increased standard of care because they've got something going on, right? That's why
Yeah.
you did the test. And then if that cutoff is, if they test higher risk, then I'm guessing it's clinical judgment on what's going on what you do from there. Do you increase their monitoring? They still can go
Mhm.
home, or is it high enough that you keep them in hospital?
Yeah, we I think the best an ideal way to be using this is to have like an algorithm that people are following. And at our hospital, we came up with an algorithm to help providers encourage them to use this test and then kind of triage what to do if it's less than 40, what to do if it's greater than 40, what to do if it's greater than 85, as you alluded to, the higher risk of adverse outcomes. And so if we're less than 40, like you said, we're happier with them being discharged, usual follow up. And then if greater than 40, then your suspicion is heightened. And I think different providers kind of interpret it and use it differently. I like using this test to help me risk stratify my patients because, it can help patients even with the diagnosis of preeclampsia have some time in the outside world. Now, you are doing you are monitoring frequently, but then say, like, for example, the ratio was 42, and then I would check it again 2 weeks later and I let them out into the world and I'm seeing them, then I would check it again 2 weeks later. And if it bumps, I would say, like using the data greater than 85, my stance would change for myself clinically, but to then say, you should probably be admitted. I really recommend that given your risk of a bad outcome for mom or baby happening is higher now with that number.
And that answers my next question, which is, do you repeat it in 2 weeks if it's, either, low, but they're still showing symptoms or increasing symptoms, or, if they're right in that sort of cutoff range, you repeat it again. And Dr. Chokshi, you repeat again for
Yeah,
patients.
we've had a couple of cases where, it was negative initially, patient did well, spent like a couple of weeks outpatient, and then suddenly they get a bump in their blood pressure and we repeat it and it comes back significantly higher. And that's the test, as you said, for its prognostic value. It's a fairly good test. It's the
Yeah.
best test we've had in a very long time for preeclampsia.
Yeah, it's been a long time coming for sure. I'm aware that we are over time, so I'm going to try to wrap up with just two follow-up questions. How can somebody, a patient, um, advocate for this test? If so, we get patients all the time who's like, I went to labor and delivery and they're keeping me, but they're not really sure what to do with me. And they don't know if it's because I have this comorbidity, or, they're either going to deliver me tomorrow or I'm going to be here for 6 weeks. And I will ask them, have you had this test? And, they haven't, or they don't know if they have. How can a patient ask their clinician about this test and whether it's right for them?
Yeah.
I think
Go.
it's great to bring it up because you as the patient are the biggest advocate for yourself, and so bringing up the test, I think with the results of the PRACES study, Beacon, all that going forward, there is we're working on provider education on the topic, but still it's not a test that's available even at every hospital, which is hard because it would be nice to have that at every hospital for
Yeah.
fast, quick, easy risk stratification. But every hospital doesn't have it. And even some of the hospitals that do use it have to use it as a send out test. So it takes a couple of days for the results to come back usually. The first thing would be to bring it up and ask your doctor, do you have this test available here? And then have an honest discussion about, are you right for the test? Can I get that test? Or does that institution have a method of being able to get that test sent for their patients?
And all institutions in the U.S. can send out to either LabCorp or Mayo Clinic if that option is available to them if they don't have the equipment on site. So I would just say if your clinician says, "Oh, we don't do that test here," ask them further about a send out test to LabCorp or Mayo Clinic, because those are options. Comes with that an additional barrier of time because the sample has to get out to the testing facility, be run, and then the results returned. So maybe that's not useful in every case, but could certainly be useful in a number of situations.
Yeah, we use it as a send out. It comes back
Do.
fairly quick. We have 24 to 48 hour turnaround with a send out with LabCorp. So, yes, we don't, it would be nice to have the equipment to run it in-house because obviously that's like much more of a point of care test. But even in institutions that don't, there is some resistance and reluctance from providers because it's a newer test. There's not been enough time for the data to mature.
Mhm.
ACOG has been very conservative in their recommendations. They say it can be used as a complementary test. It's obviously not the end all be all, which no test can be.
Yeah.
So I think this is something that's going to get wider acceptance. It's going to take some time, but as a patient, absolutely advocate for yourself. It'll just help. It'll help you. It'll help the institution. It'll get some more people to understand how this test works.
Great. I have so many more questions for both of you, and I want to be, I'm already being disrespectful of your time. So I hope to have you both back on. I'd love to talk a little bit more about this test and also to talk about hypertension after delivery. So I'm going to wrap it up for today. Thank you so much for this very candid conversation about how you're using the tests, how patients can advocate for themselves to use it, and to know that again, this is another tool that can help prepare the patient for what's to come, right? And give them some peace of mind. If it comes back low, they can go home and hopefully get some sleep at night, but also receive the appropriate care if that test comes back that shows that that prognostic test showing that they're at high risk. Thank you again. Thank you everyone who's online. There are a bunch of great questions in the chat. We will get some answers posted in the Facebook Live feed to some of those questions as well. Thank you for your time. Thank you for your expertise.
Great, Carara.
And
Nice meeting you,
thank
Dr.
you
Anwer.
on this last day of Preeclampsia Awareness Month. I look forward to talking to you all soon. Thank you.
Thank you so much.
Bye-bye.
Bye.